So today I'm going to talk on pulmonary hypertension in a non-cardiac surgical patient. Disclosures: anything wise in the presentation you should credit to the many experts who have preceded me, and anything foolish, please assume it as my error. These would be the objectives of my talk. We'll go to the history and introduction first. Then we'll look at the classification, pathophysiology, and risk estimation of these patients who have pulmonary hypertension and who are posted for non-cardiac surgeries. We'll look about the management and newer modalities, and then there is a take-home message. I always wonder how they used to anesthetize the patient in olden days, maybe like this. I'm glad I'm not in that era, or this talk wouldn't be happening. A bit about history. Galen, way back in 2016 AD, proposed the first physiological system. So this was way back in 216 AD. Ibn al-Nafis in 1200s, he said that he defied the Galen's theory. So he did not believe in the Galen's theory and he further progressed the work. And Ernst von Romberg in the year 1891 gave the first description for pulmonary vascular sclerosis. Werner Frossman in 1929 did the first right heart catheterization, and minded it was on himself. In 1900s, in 1972, there was a drug which was called aminorex, and this was especially used for weight reduction. And this drug had the side effect of pulmonary hypertension, which was first time observed, and that is why the drug was withdrawn. So this concept of pulmonary hypertension started to gain momentum in 1970s. So from that era, we have come to an era of advanced cardiac monitoring, especially with RV strain analysis and all the advanced modalities. So it has been a remarkable progress. So to begin with, we all say that behind every successful man, there is a woman. So let us call LV as the man and RV as the woman. So for a good coordinated movement, there has to be always good coordination between both of these. So this is how a normal cardiac patient looks like. In systemic hypertension, there can be some problems, but if there is pulmonary hypertension, then there are definitely going to be disastrous consequences. So if you look at the literature, what literature says is pulmonary hypertension affects 1% of the global population worldwide and 10% of the people above the age of 65 years. Now, pulmonary hypertension poses a risk in the perioperative period, especially when the patients have pulmonary hypertension. The morbidity and mortality rates increase, and they can range between 20 to 43% in terms of morbidity, and the mortality can be between 10 to 19%. Defining pulmonary hypertension. So way back in 1970s, first attempts were made to define pulmonary hypertension. The first World Symposium on Pulmonary Hypertension was held at Geneva in 1973, wherein they defined pulmonary hypertension and they said a patient has pulmonary hypertension if the mean pulmonary artery pressure is more than 25 mm of Hg. So as the years progressed, there were different world symposiums. So second World Symposium on Pulmonary Hypertension was held at Evian in 1998. Then the third was held at Venice in 2003, wherein first time they described pulmonary arterial hypertension along with pulmonary hypertension. Then there was the fourth World Symposium on Pulmonary Hypertension, which was held at Dana Point in 2008, and there were no changes in definition. The fifth was held at NICE in 2013, wherein the concept of pre-capillary and post-capillary pulmonary hypertension came into existence. The sixth World Symposium on pulmonary hypertension was held at NICE, and herein now they have changed the definition of pulmonary hypertension, and now the current definition says that a patient is categorized to have pulmonary hypertension if mean pulmonary artery pressures are more than 20 mm of Hg. Along with that, definitions of pre-capillary and post-capillary pulmonary hypertension have also been introduced. Now, recently in this year, the 7th World Symposium on Pulmonary Hypertension took place on June 29th and 30th June and July 1st, and it was held at Barcelona. There are no major changes in the definition of pulmonary hypertension. So look at this image. What do you see here? The students are trying to study, but they are sitting on the wall. So how is this possible? So if you just change the perspective, you will understand the truth. So also, when we are dealing with pulmonary hypertension, we need to keep our perspectives open. So what does World Health Organization say? So World Health Organization has classified pulmonary hypertension into 5 groups. So let us see what are these 5 groups, one each at a time. So group 1 patients are patients who have arterial hypertension, which is due to idiopathic causes or maybe some associated conditions. So what are those conditions? So in a few subset of patients who have been on few drugs, or patients who have connective tissue diseases, patients with HIV or portal hypertension, or patients who have congenital heart diseases or schistosomiasis are included in group 1 type of pulmonary hypertension. The group 2 category as proposed by the WHO, includes patients who have pulmonary hypertension associated with left heart disease. So basically, all the patients who have valvular heart disease, patients who have systolic dysfunction or diastolic dysfunction are included into group 2 category of patients. The group 3 patients, according to WHO, are the patients who have pulmonary hypertension associated with lung disease. So basically, these are the patients who have COPD, interstitial lung disease, sleep disorders, or alveolar hypoventilation. The group 4 patient includes patients who have pulmonary hypertension associated with pulmonary artery obstructions. That is basically patients who have chronic thromboembolic episodes or pulmonary hypertension because of it. So they can be either operable or non-operable. And the group 5 patients include rest of the patients who have other disorders like the hematologic disorders or systemic disorders like sarcoidosis, metabolic disorders like glycogen storage diseases, or due to tumor obstructions or chronic renal failure. So these are the 5 groups into which the patients are categorized who have pulmonary hypertension, and this is the WHO classification. Now, there is an important concept in pulmonary hypertension which is called as pre-capillary pulmonary hypertension and post-capillary pulmonary hypertension. So look at this image. What do you see here? There is obviously flooding in this region. If you also see this image, definitely floods are occurring in this image also. But here, the etiologies are quite different. In the first image, if you see, there is excessive rainfall, while here, the reason is tsunami. So similarly, pre-capillary and post-capillary pulmonary hypertension, although they look similar, but the etiologies are different and they are classified in a different way. So how do we do that? So basically, a patient is classified to be having pre-capillary pulmonary hypertension when the mean pulmonary artery pressures are more than 20 mm of Hg. The pulmonary capillary wedge pressure is less than 15 mm of Hg, and the pulmonary vascular resistance is more than 3 Wood units. So basically, WHO group 1, 3, 4, and 5 patients are included or classified as patients having pre-capillary pulmonary hypertension. Whereas in contrast to this, post-capillary hypertensive patients will have mean pulmonary artery pressures more than 20 mm of Hg. Pulmonary capillary wedge pressure here is more than 15 mm of Hg, and the pulmonary vascular resistance is less than 3 Wood units. So basically, the group 2 patients and a few patients from the group 5 are classified as having post-capillary pulmonary hypertension. So the important difference is between the pulmonary capillary wedge pressure and the pulmonary vascular resistance. Now, there are different grades according to which we classify a patient of pulmonary hypertension. Basically, these are based on echocardiography. There is no definitive grading of patients with pulmonary hypertension based especially on echocardiography. But as a rule of thumb, most of the people will agree to this, that patients who have mean pulmonary artery pressures between 20 to 40 are classified as having mild pulmonary hypertension. Patients who have mean pulmonary artery pressures between 40 to 55 are classified as having moderate pulmonary hypertension. And patients who have mean pulmonary artery pressures more than 55 are classified as severe. They can be also classified based on systolic pulmonary artery pressures, but this is very less used, or it is rarely used. Basically, they are classified based on the mean pulmonary artery pressures. Now, the right ventricle is quite different as compared to the left ventricle. The right ventricle, as I call it, it's like a Pandora's box. So you never know what is going to come out. So look at this first image over here. So here, this is a graph plotted of the left ventricle. So on the x-axis, we have the systemic pressure. On the y-axis, we have stroke volume. So if you observe closely, as the systemic pressure increases, there is some decrease in the stroke volume. So there is some amount of decrease in the stroke volume as the systemic pressure increases, but that is not very significant. In contrast to this, if you look at the right ventricle, the pulmonary artery pressure here is plotted on the x-axis and the stroke volume of the right ventricle is plotted on the y-axis. If you see here, as the pulmonary artery pressure increases, even by fractional amount, the stroke volume of the right ventricle is decreasing to a great extent. So basically, the patients who have pulmonary arterial hypertension are high-risk patients, and any minor increases in them in the perioperative period can lead to decrease in the stroke volume of the right ventricle, which can be disastrous. Now, the pathophysiology of pulmonary hypertension, there are multiple etiologies which have been proposed, but usually they say initially the patients have medial hyperplasia followed by intimal proliferation, and then there are plexiform lesions. Now, different drugs which are available in the market are based on different pathways. And basically, these drugs act through the endothelin pathways or the nitric oxide pathways or the prostacyclin pathways. So few of the drugs like bosentan, sildenafil, and epoprostenol, these are all the drugs which are based on these different pathways. So I'm not going to go into details of this because of the dearth of time, but at least we should be knowing that 3 major pathways occur, or the drugs act on 3 main pathways, and namely they are the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. Now, why is it important to evaluate these patients? So if we can tell if who has significant risk factors, we can answer two questions. First is who can land up in perioperative complications, and second is who needs a tune-up before surgery and who doesn't. Now, my question is, would you like to take this car on a road trip? 50% of you would say yes, 50% of you would say no. Now, if I show you the next image, my question is, would you still like to take this car on a road trip? Now, almost all of you will say no. So, as such, preoperative assessment of these patients who have pulmonary hypertension or catching this subset of patient is very important. Now, what are the clinical features associated with right heart failure? So basically, these are anorexia, weight gain, hepatomegaly, edema, ascites, and distended neck veins. The basic investigations that we all do in this subset of patients are ECG and chest X-ray. So ECG can show a right axis deviation, right ventricular hypertrophy, or RV strain kind of pattern. X-rays can show peripheral hypovascularity, that is pruning, or there can be prominent hilar pulmonary arteries, or there can be an RV enlargement which can be seen on a lateral chest X-ray. CT scan is a great modality to know the size of the pulmonary artery and also the branching. So in some subset of patients, we subject them for CT scan. Also, ventilation perfusion scan, that is VQ scan, and also cardiopulmonary exercise testing is also used in a few subset of patients. Cardiac MRI is a great modality, and it can give us simultaneous assessment of the morphological and the functional status of the right ventricle as well as the pulmonary artery. In fact, it is better than CT scan and echo. Now look at this image here. What do you see? A politician is trying to talk to people in the flood affected area. A child is being subjected to violence. But is it the truth? Well, absolutely no. So when dealing with these patients of pulmonary hypertension, you should never forget of the important modalities, that is echocardiography. So basically, it can be transthoracic echocardiography or it can be transesophageal echocardiography. And catching these patients in the preoperative period is very important. So here you see in one such patient, this patient has a dilated RA and an RV. So basically here we are dealing with some kind of RV dysfunction or maybe some kind of pulmonary hypertension. This is second image over here. This is a transesophageal image. Again, you can see an RA and RV has been dilated. So basically you need to catch these patients in the perioperative period. So based on echocardiography, you can grade pulmonary hypertension, and it is not as difficult as it seems. So there are a few basic steps that you need to do. I'll just go into it. I'll not go into the details, but I'll just try to explain it to you in a few minutes. So basically, you need a good four-chamber view, apical four-chamber view, or maybe some other views like an RV focused view for knowing whether the patient has tricuspid regurgitation or no. So once you have a good view, then you switch on your color Doppler and then you place your continuous wave Doppler. So now once this is done, you can trace the tricuspid regurgitation jet velocity. And based on these velocities, what you can do is there are a few formulas based on which you can estimate the systolic pulmonary arterial pressures and the mean pulmonary arterial pressures. So basically, systolic pulmonary artery pressures is nothing but it is the maximum TR jet velocity into that is squared. So that is basically here in this image, if you see here, the maximum TR jet velocity is 3.9. So if you square that, it will come to 60.79. And you just need to add the right atrial pressures to this, and you'll be getting the systolic pulmonary artery pressures based on echocardiography. The mean pulmonary artery pressures can also be derived from the systolic arterial pulmonary artery pressures, and the formula is 0.6 into systolic pulmonary artery pressure plus 2.1. So if you see here, in for knowing the CVP or knowing the RA pressures, what we need to do is we need to go to the subcostal view. You need to look at the IVC. So in this patient, I have looked at the IVC. So here you see the IVC is collapsing nicely. The IVC doesn't seem to be dilated. So basically, we are dealing with CVP or RA pressure somewhere between 0 to 5. That is on an average, we can take 3. So if you put these numbers in the previous example or the previous slide that I've shown, the systolic pulmonary artery pressure comes to around 64 in this patient, and the mean pulmonary artery pressure comes to around 40.5, which is elevated. So similarly, this is one technique to look at pulmonary or diagnosing the systolic and the mean pulmonary artery pressures. The another way of also knowing the pulmonary artery pressures is you can just go to the short axis view, that is a Panasonic short axis view near the aortic wall, and then you can focus your view on the pulmonary artery and switch on your color Doppler. And if you are fortunate enough to get a pulmonary regurgitation jet, then based on this pulmonary regurgitation jet, you can diagnose mean pulmonary artery pressures and diastolic pulmonary artery pressures. So basically, mean pulmonary artery pressures, again, here the formula is 4 into early PR velocity. So in this patient, this is a patient who has PR, pulmonary regurgitation, and this is the early velocity of the PR jet, and this is approximately around 1.2. So squaring that, you will get 12.07 plus RAP, that is around 3. So here the mean pulmonary artery pressures are 15.07. and the diastolic pulmonary artery pressures are 4 into late PR velocity. So this is the late PR velocity, and that is 5.79 plus 3, that is the CVP, and it comes to around 8.79. So this is how you estimate pulmonary artery pressures based on echocardiography. The RV assessment can also be done with the help of a score called as TAPSE, that is tricuspid annular plane systolic excursions. So this is how a TAPSE is calculated. Values more than 1.7 are usually considered normal. So here the value is 2.4, which is good. In this image, you can see the RA and RV is dilated, and you should never forget to look at the coronary sinus. So here you see the coronary sinus is dilated. So basically here, somewhere we are dealing with elevated pulmonary artery pressures. Along with this, invasive modality for monitoring the pulmonary hypertension is by right heart catheterization, and you can always put in Swan-Ganz catheter. So this is how a Swan-Ganz catheter is inserted. So here we have located the IJV and we have got the access. Now further, we are going to insert the guide wire. So I've inserted the guide wire now. Then there is a sheath called as introducer sheath. After that, we need to introduce this sheath. And once this sheath is in place, then we put the Swan-Ganz catheter through this sheath. So this is a Swan-Ganz catheter, that is a pulmonary artery catheter. So based on the waveforms on the monitor, we determine whether it is in RA, RV, or pulmonary artery. So now we have advanced the Swan-Ganz catheter. So once this catheter comes into a pulmonary artery, you will get a good systolic and a diastolic waveform, and you will get two values. And if you inflate the balloon on this pulmonary Swan-Ganz catheter, then you will get a trace something like this. So this is basically the wedge pressure. So this is how invasively you can estimate the pulmonary artery pressures. Now, why is this important? This is important because we need to estimate the risk of the patient in the perioperative period. So depending upon the clinical signs and symptoms, depending upon the hemodynamics, that is to maybe after floating a pulmonary artery catheter, or based on echocardiography and some lab parameters like anti-proBNP levels, we can risk or grade the patients into low risk, intermediate risk, or high risk patients. Now, there are a few calculators which are available online. And if you just put in the numbers, it will calculate the scores and give it to you, and it can tell you what is the risk of the patient in the perioperative period. So these calculators are especially used in non-cardiac surgeries, and Reveal is one such calculator. The current version is Reveal 2.0, and this is available online. And if you just put on all the criteria and just mark everything, then you will get a score. So if the score is less than 6, we say the risk group is low, and predicted 1 year survival is more than 94. If the Reveal score is between 7 to 8, it is intermediate risk. And if the Reveal score is more than 9, then we call it as high risk. Literature, again, there are a lot of studies in non-cardiac surgeries, orthopedic patients, also the other patients, the critically ill patients, patients who are subjected for major non-cardiac surgeries. So there is a lot of literature. But if you scan through this literature, then there are a few common factors or few common risk estimates in patients. So what are those risk estimates? So basically patients who have arterial hypertension, which is either mixed or post-capillary, patients who are ASA class 2 or more, patients with on having right axis deviation on ECG, anti-proBNP levels more than 300, on transthoracic echocardiography, evidence of right ventricular hypertrophy, or based on catheterization, a mean pulmonary artery pressure of more than 45. Also, the duration of anesthesia, perioperative, use of vasopressors, emergency procedures. So all these factors, if the patient has all these factors, we usually say the patient is at high risk category and bound to have some problems in the perioperative period. Now, basically, whenever you are dealing with a patient with pulmonary hypertension, it is a juggling between SVR and PVR. These are the anesthesiologists who are trying to maintain the balance intraoperatively while the surgeon is enjoying the view. But jokes apart, the goals in dealing with such patients are the PVR should always be low, or the PVR should always be less than SVR when you are dealing with a patient with pulmonary hypertension. And the goal with SVR is to maintain the SVR and avoid precipitous fall in systemic vascular resistance. So basically, the management goals or the hemodynamic goals are systolic blood pressure should be more than 90 mm of Hg and or more than 40 mm of Hg above systolic pulmonary artery pressures. The mean arterial pressure should be more than 65 and or 20 mm of Hg above mean pulmonary artery pressures. The mean pulmonary artery pressures, we should try to keep it below 35 mm of Hg or 25 mm of Hg lower than mean arterial pressures. The PVR to SVR ratio should be less than 0.5. RAP should be at lowest, and the mean arterial pressure should be more than 65 mm of Hg with that low RAP. And the cardiac index should be maintained preferably above 2.2 liters per minute per meter square. So again, if you look at regional and general anesthesia, what the references say or what the literature says. So patients can be subjected either to regional or general anesthesia. There are a few drawbacks or pros and cons with both of these techniques. In regional or neuraxial blocks, usually the sympathetic tone and SVR is reduced. Precipitous hypotension can occur, especially when such patients are subjected to spinal anesthesia. Epidural and peripheral nerve blocks are the preferred modalities, and also these regional or neuraxial blocks can help in postoperative pain control, which is very important in this subset of patients. The general anesthesia can also be used in these patients, and it is usually preferred in major and prolonged surgeries and patients with severe PH. Inhaled pulmonary vasodilators can be administered through this circuit. So these are the benefits if the patient receives general anesthesia. But always remember, these patients are more prone to perioperative complications. So basically, whatever you do, whichever technique you choose, make sure that you are skilled enough in these techniques, like this driver is doing in this image. The monitoring of these patients basically includes multimodality. So basically, ECG, basic is monitoring like the ECG, pulse oximetry, arterial line is important. Along with that, in few subset of patients, you can thread in a Swan-Ganz catheter or a pulmonary artery catheter. T, as I call in, is the third eye for the anesthesiologist inside the operating room. And as such, monitoring these patients with transesophageal echocardiography can give you great inputs about the condition of the patient. Recently, with the advent of artificial intelligence and HPI, that is hypotension prediction index, these technologies can also be included in monitoring of these patients, especially high risk patients. So HPI is one such technology, and there are studies going on this, research coming out. So let us see what it has to offer regarding this subset of the patients in coming era. So how do we manage these patients perioperatively? So basically, in the pre-medication, you need to give mild anxiolysis. You should avoid deep sedation in these patients. You should continue other pharmacotherapies of these patients, especially on the day of surgery. Induction can be like a standard induction. Pre-oxygenation is always important in these patients. Fentanyl or morphine can be used. Etomidate can be used in these patients. Rocuronium, cisatracuronium can be used. Make sure that the intubation is as quick as possible in this subset of patients. And you should not use nitrous oxide in these patients. And isoflurane, sevoflurane, or inhalation agents can be used in this patient. Regarding the ventilatory strategies of these patients, we should avoid high tidal volumes and PEEP. The tidal volume usually should be between 4 to 6 ml per kg. Permissive hypocapnia can be allowed in these patients. The target PaCO2 levels are between 30 to 35. Metabolic acidosis has to be avoided. The pH preferably should be kept above 7.4. And there is a concept called as luxury oxygenation, that is increase of FiO2, or you should increase the FiO2 rather increasing the tidal volume and PEEP in this set of cases. And goal-directed fluid therapy with hemodynamic monitoring and maintenance of normothermia in the intraoperative period is essential in these patients. So there are different agents or inotropic agents which you can use in the perioperative phase if required. So few of these are milrinone, and the doses are given here. Dobutamine, prostacyclin, nitroglycerin, sodium nitroprusside can be used based on the clinical scenarios. Similarly, a few selective inhalative vasodilatory agents like iloprost, nitric oxide, prostacyclin, inhaled milrinone can be used in this subset of patients if required. Levoncimandane is another wonderful drug which I have used in few subset of patients, basically not in non-cardiac surgery, but I have experience of using levoncimandane in cardiac surgical patients, especially who have severe pulmonary hypertension, and it works wonderfully. Similarly, nitric oxide can also be used, and nitric oxide, you can just connect it. There is a special delivery system for delivering this nitric oxide. We usually use this modality in heart transplant patients or lung transplant patients, and anything between 5 to 20 parts per million can be used, and they have absolutely beautiful results when being used. Similarly, last stage, if you are dealing with a patient who is refractory to all these therapies, and if the patient crashes down, if the setup is good, if financial constraints are not there, then always you have an option of putting the patients on veno-arterial ECMO. Similarly, RVAD implantations, that is right ventricular access devices like Impella 2.0, which is currently in use. So all these things can be used, but provided the finances are good. But always remember, the intraoperative part is one thing, post-operative part is one thing. And whenever you are dealing with these patients, never try to celebrate too early, because if you don't monitor these patients in the post-operative period, definitely you are going to land up into trouble. So don't land up into a situation like this, wherein you are catched off guard in the post-operative period. So basically, in the post-operative period, always remember to monitor your patients, keep a watch on the atrial tachyarrhythmias, make sure the patient get adequate pain relief, because pain again can be a precipitating factor in the post-operative period. Goal-directed fluid inotrope therapy can be used, and always remember, resume the preoperative therapeutic regime as early as possible in this subset of patients. So recently, again, there are a few studies coming up, especially with the RV strain and rest of the modalities. So let's see how these studies can be inculcated or incorporated into knowing the outcomes of these patients. So studies are going on in this field. Let's see what it has to happen. A few of my clinical experiences. So one patient I had who had or who was subjected for an orthopedic surgery. Basically, it was a femur nailing. This was long back, and post-operative day 3 and 4 he had dyspnea. So we tried to know the cause, and the cause was pulmonary embolism. So basically, you can see a nice pulmonary, embolus sitting in the right pulmonary artery. So this is an TE image. Another patient which I had who was posted for renal cell carcinoma, the patient had an thrombus in the hepatic part of the IVC. So basically, we did this surgery under TE guidance. So you can see this is a thrombus sitting nicely in the inferior vena cava in the hepatic part of the IVC. Another patient I had who was going to be subjected for non-cardiac surgery, that is umbilical hernia repair, but in the preoperative phase, because of proper echocardiographic screening, we could catch him. And when we did the transthoracic echo of this patient, you can see the RA and the RV is dilated, also the coronary sinus is dilated. So whenever you find this kind of features, the first thing that comes to your mind is whether the patient is having congenital heart disease. And as we did further tests, that is, this is the saline agitation test, which is seen over here. When we did it further and we subjected him for a TE, so you can see the patient had an ASD. This is the sinus venosus kind of ASD. You can see this is a 4D image. This is from the LA perspective, and this is the sinus venosus ASD. So we first subjected him for non-cardiac surgery, and then he was operated for hernia. So the take-home message is, whatever the situation be, keep cool like we guys did in this recent World Cup. And if you have a good knowledge, if you are keeping your head cool, then most of this critical situation, especially emergencies, can be taken care of. So my take-home message is a thorough understanding and workup of the patient with pulmonary hypertension is important. Multidisciplinary approach is necessary. Always remember, you should learn these newer modalities, especially like echocardiography, and make a habit of doing your own echocardiography. Always optimize these patients if possible, and you should never rush in such patients for elective surgeries. Use advanced modalities like transesophageal echocardiography, PA catheters, cardiac output monitors, especially in high-risk patients, and always be eternally vigilant throughout the procedure, especially in post-operative phase. These are a few of my references. Thank you.